we're going to be transitioning into talking about the pillars of the early journey. And I know myself that after diagnosis, there's just so much on our plate that there's a lot to conquer and we want to do it all. And so I think this is going to be a really great discussion to help us do that. Our first speaker is going to be Dr. Castro, and she's going to be talking about the clinic and steroids, and welcome. And so enjoy, everybody.
Thank you. Good morning, everybody. Thank you for the invitation. I'm so happy to be here and share this part of my presentation. I'm very open to question. If you guys want to stop me, ask something, just let me know. I'm a neuromuscular physician. I'm a child neurologist, then I did neuromuscular training. I do only pediatrics for now until 21 years of age. Hopefully I will actually start seeing adults as well very soon. Very excited about that. And I'm in Dallas. I'm in the University of Texas Southwestern. So this is my background. I actually came from Colombia, from Bogota, many years, 20 years ago. And I ended up finding my path to this beautiful area in medicine. So very happy to do it. So multidisciplinary care, you know, when I started working with patients with Duchenne, we did not have at the beginning this very well organized setting that we have right now. It took us a while. And that's something that I always think about different clinics in the country. Not everybody has everything. Not everybody has everything perfect. So it takes time. But the first person that we have to think and always remember is the pediatrician. And it's the person who actually is going to give the diagnosis, the person that is actually going to think about this. So we have been working on educating them and making them aware of this condition. I tell you a story. One of my families, a Hispanic family, they went to the doctor and they told him, something's wrong with my child, she said to the doctor. And he said, no, everything is fine. Before he was leaving, he was going out of the door and she grabbed him from his arm and he said, you have to look at him standing up from the floor. So the child went on the floor and he stand up with his full gower. He finally got diagnosed in 2 seconds, right? So that is the problem, that if we don't educate pediatricians, if we don't include them in this, we're not doing anything. So to me, that's the first step. The second one is something that I keep telling the companies all the time. We need a network. We need a way for the pediatrician or neurologist to communicate with neuromuscular specialists easier. Because it's not fair if I'm a mom and I'm dealing with this and I'm waiting to get a referral and you have to wait for a month, 2 months, 3 months. That's not fair for anybody. I think I'll be, going crazy. I'm a crazy mom baseline. And I will be killing somebody to try to get my son into an appointment. So we do need to work in that part, and I don't think we have done a good job in that area. So why is that multidisciplinary care is important? It's because we have people that are interested in the same thing, that are following the guidelines, that are trying to help the patient as a whole. And I'm sorry, I'm giving you my back.
No, you are fine.
Giving a whole approach, a holistic approach of the patient. But it's not easy, like I said. There are many centers that don't have many of these important people in the group because they don't have funding. So as physicians, we do have to have certain number of patients. They give us the numbers called RVU. You have to get to 4,000 in a year, and if not, they don't pay you a bonus. Like, it's not nice already, right? Like, we are working against the clock. And I'm sorry, but I'm not gonna sit with my Duchenne patient and talk for 10 minutes and say goodbye. It's not gonna happen. So my appointments take around 3 hours, 3.5 hours, and then I have to have these people interested and being very dedicated to the condition. And how do I help them? I need to be able to help them pay in their time to be able to come to my clinic. So it is complicated, but all of these people that are here in this slide are the ones that ideally we should have in our different clinics. So each hospital has a different model. And what I was able to create over the last years was that we have 2 clinics for younger kids. So we divided at 15 years of age. So under 15 is two times, where is the slide? Oh, here. 2 times a month, and then one Thursday of the month is for adults. So I see patients until 21 years of age. The families arrive 1.5 hours before. They get X-ray, they get echocardiogram, PFTs, whatever they need to get, and then they are placed in a room, and they have a sheet of paper with all the different providers they are going to see, and each person is going to have 45 minutes. This is all very nice, but something that I'm going to say down the road is that it's a lot. It's a lot for the family. It's a lot for the patient, it's a lot for me. I go home and I just die. I don't talk to my children, I just go straight to bed. It's a really busy day. And sometimes I question, should we be doing it that way? Should we be giving so much information in one day? We're doing it because we want to keep families having to, avoiding the trip back and forth. But at the same time, how much information are you guys taking home with you? So again, neurologists, my work is to be able to lead this clinic, to be able to keep that communication between the other providers, myself, and the patients, to provide education, managing expectations. I have a clinic that is around 50% Hispanic, and it's a completely different beast. It's completely different medicine because culturally, there are a lot of cultural barriers. There are language barriers. That's my first language, Spanish, and sometimes I feel they don't understand what I'm saying. And I'm using all the words that I know in different Spanish, and it doesn't work. It's a lot. So there are so many things that we have to fight against in these multidisciplinary clinics that I think when we take so much time, we're taking probably a lot of that understanding away. I think, it's just go and check the box and go home. So I don't know. I'm not against multidisciplinary clinics. I think we have to find a better middle ground. I talk about every visit, I talk about new research because I think people have to be knowledgeable. They have to understand what is going on. We talk about every system. So I have fellow, I have resident, I always ask them, talk to me head to toe. So we start brain, eyes, eating. Every single system we talk about and we make a plan for it. And then we summarize the care at the end. In terms of medication, you will, early in the journey, you're gonna get exposed to a bunch of medications, and it's scary. And your child goes from having to take maybe Tylenol occasionally to having to take now 3, 4, 5 pills at the same time. It's extremely scary, and it's something that unfortunately we do have to do right now because that's the only option we have, right? We do steroids, we start them at around 2 to 5 years of age. We have somebody from nutrition today that is gonna talk to us about the nutritional part that I think is the most important part of all, I will say. If we did better on that, we'll do better on everything else. We have to start cardiac medication that before we didn't. I started working with patients with Duchenne 11 years ago, and we didn't have much cardiac care. I was graduating patients at 21 with lisinopril 2.5 milligrams, like nothing, right? So now we start them early and we put them on 3 medications. We know you do vitamins and so on. That's where one of the disparities comes because I have families that have private insurance and they have more money and more education, and then they go and get all the supplements in Costco available, right? Like coenzyme CoQ10 and all of them. And then you have my Hispanic family who doesn't have money for anything, and obviously they cannot get into that. So there is a lot of that disparity in care. So in terms of the mental, emotional, and social support, so to me, the most important things, 1, nutrition, and 2, the mental health as well. We are in need of a lot of things in these clinics, and I think most of us are lacking this part in management. We need to do neurocognitive testing for these children. Neurocognitive testing, not the one that you get at school. At school, they do psychometric testing. But you have to complement that with neurocognitive testing to be able to do a full assessment of the kid, to be able to say, yes, it is autism, no, it's not autism, this is the 504, this is what you need. My patients cannot access neurocognitive testing most of the time. Even with private insurance, there are no appointments. Access to psychologists who understand DMD, and access to psychiatrists. Many times I end up managing the psych medications. I end up starting my kids on anxiolytics, antidepressants, and so on. And it shouldn't be that way, but there is no people to do it, right? So I just have to do it. I was trying to find a psychiatrist for my 7-year-old with ADHD, and it's mission impossible. I have insurance, doesn't matter. There's just not enough people, and they usually want to have cash pay. They don't take insurance. So the barriers, very expensive, usually not covered by insurance, like I was saying. limited number of diagnosticians. So the people that do the testing, that do the neurocognitive testing, you have to have people that speak both languages to be able to address really these, the real issues that are going on with the child. Limiting number of providers, no insurance coverage, time and transportations. So the benefit of the care, multidisciplinary care, like I was saying, less trips to the hospital, standardized care, so everybody's doing the same or trying to do the same, following the guidelines, proactive and more effective care. But what are the disadvantages? Like I was saying, long appointments, 3 to 4 hours for a child, they wanna get out of there after half an hour. They lose their minds, they go bored, and like, what else do we do, right? Listen to these doctors coming in and out talking about things that I don't understand anything. Boys get bored, hungry, it's overwhelming, maybe too much information. So to me, all of these beginning of the pathway with Duchenne, it's the time where the families, I think, I would love to have the families giving us feedback. How do we manage this part? How do we make this better for you families, for the patient, for ourselves? I think that guidelines are good, but the guidelines don't feed every single person and don't feed every single community. So it's a lot of information, there's a lot of things that you have to learn, a lot of things that you have to go through, but it's a very important time to you give your point of view as a family, okay? Always ask questions and always try to create that relationship with your provider. I'm gonna talk about the corticosteroids. It's for my colleague, Dr. Panda is not here, he got an emergency. So I'm just gonna go through the corticosteroids really quick, not gonna take too long. Because unfortunately, this is what we have as an option right now. It's the only really treatment besides the exon skippings for some of the patients. These are actually not my disclosure, these are his. So we'll talk about steroids. Okay. So steroids are used for many different conditions actually, but in Duchenne they are quite important. Corticosteroids are produced by our adrenal glands that are sitting on top of the kidneys, but for kids with Duchenne, we do need higher dose of those to be able to help us with some of the inflammation and some of the fibrosis and some of the things that are happening actively in Duchenne. Many clinical trials have shown clearly that if we start patients on steroids, the patients are going to do better in certain things, motor function, the ability to walk, and so on. Obviously, that comes with a high pay, that it's all the bunch of side effects that and you guys know because you have children with Duchenne, all the side effects that we give you, that I don't think is fair. At the same time, again, I have my conflicts in my mind about multidisciplinary care being too long, and side effects causing so many corticosteroids causing so many side effects for kids. So we know they're good. The biggest reasons are we want to prevent scoliosis. After we start using steroids, we don't have to have really kids getting, really rarely, I have a kid that needs a scoliosis surgery. We know that it helps with their breathing function. We know that they have an effect on the heart. We know that they will help them walking for longer, more time. But where are the side effects? I think somebody showed already a slide like this. There are a lot. And the biggest issue to me is weight gain. That's why I'm saying nutrition is an important part that we have to address better. And two, the behavioral changes. I have a kid who, everybody says 1/3 of the patients with Duchenne have some kind of behavioral, academic, or some kind of, difficulty in that area. I think it's way more than that. I think it's probably 2/3 of the patients, or at least in Texas it is. I had a kid the other day who had history of, he actually ended up killing a little puppy or something, like there was some kind of bad thing going on with pets. What do? I know I have to start them, but if I put them on a high dose of steroids, I'm gonna cause him to have more behavioral issues. So we are in front of this all the time. I know I have to do it, but I know I'm gonna cause problems. So it is what it is right now, and hopefully we'll come up with better options for patients down the road. So weight gain in Texas is a big issue. Our portions are out of proportion. It's like, I cannot understand the size of everything that is served in Texas. And the problem is that you start giving them the regular food, the same amount of food, and then suddenly they don't walk anymore, but you're still giving them the same amount of food. So obviously we end up with patients, at transition patients, 250 pounds, 300 pounds big. Behavioral problems, we talk about cataracts, delayed growth, delayed puberty, osteoporosis, obviously all of those are big side effects. I think what he wanted to say here, it's one of the difference between prednisone and the Flacicort. So prednisone is converted to prednisolone in the liver, and it's off-label, so there is not a label for prednisone to use it in Duchenne. The Flacicort has a label, and it can be used for patients 2 years and older. Prednisone versus the Flacicort. The way I explain it to the families is that we know there are studies that show that patients that are on the Flacicort will be able to walk longer for around, it goes from 1 to 3, 4, 5 years more than patients on prednisone. They may regulate their weight a little bit better, but that doesn't mean that down the road it's not going to cause the weight gain. And then we know that the Flacicort causes more cataracts than prednisone. So both of them are great, bad, but we have to use it. So both of them are the options that we have. But let's say that the Flacicort maybe tends to have a little bit of less side effects. The problem is that the insurance don't want to hear that. They want to hear, let me pay for something that is $1,000 a year versus something that it's, I don't know how much money, it's a lot of thousands of dollars. So what happened in Texas, for example, is that they used to ask us to fail the medication for a month. So I will write a prescription for prednisone. I'm confessing I'm lying to the system. But I'll write a prescription for prednisone. I'll say, well, fail the prednisone because I hate it. And I say, well, okay, we'll switch it to the Flacicort because the patient gained weight, because the patient behavioral issues, right? Now they ask us for 6 months. So that put us in a really bad situation. So each state is different, and each state deals with it different. This is one study where they compare prednisone to the Flacicort to nothing. And they treated patients and they look at different things. One of them was the strength. So you see here, for example, I don't know if I'm pointing. I'm not pointing to anything. You cannot point to anything. Okay, the light blue is the Flacicort at a dose of 0.9 per kilogram. The next blue is 1.2 per kilogram of the Flacicort. And then the dark blue is prednisone. And the one without color is placebo. And you can see that if you compare it from baseline, muscle strength is the one we do, hold it here, do these, all of this testing. If you compare from the time, the baseline, to 12 weeks, you see that the patients on the higher dose of the Flacicort and the patients on the prednisone dose are the patients that have more loss in function, like more loss of strength, compared to the one on the Flacicort that stays more, let's say, more stable or with the same strength as they started, or close to the same strength as they started. This is clear, it's better to see it this way because it shows the same, right? It shows the patients on the Flacicort at 0.9, that's the red line. It shows that the patients actually perform better up to 52 weeks of the study. So they look at it at 12 weeks, they look at it at 24 and at 52, I believe. And they saw that the patients on the Flacicort and the 0.9 do have a better response than the ones on prednisone. So that is just, and you have the little line at the bottom that it will be placebo, meaning natural history. That's why it's important to put them on. That's why we have to talk about this, and I have to convince families to start the medication. This is looking at the weight, and the summary of this is that the patients that were treated on the 0.9 milligram per kilo of the Flacicort had less weight gain compared to the ones treated with 1.2 or with prednisone. But at the end, what I want you to see is the last one, the one here on this edge. It shows that the patients on prednisone definitely were the ones who gained more weight, but the patients on the Flacicort, they still gain weight, right? It's going to happen with both of them. It may be less with one or the other one. Then the other thing is that we know that the function may be better with the Flacicort, meaning patients can have the ability to stand up from the floor for around 2 years more with the Flacicort, so they will be able to do it at least for 2 more years compared to prednisone, 2.7 years for loss of ambulation, 2.7 years for delay of getting the hand to the mouth. So this is a large study. This was a synergy study. It included 440 patients. So there is clear evidence that they do work, they do help us. This is the study from Brenda Wong from Cincinnati, and this was a retrospective study, but it also showed that patients on the Flacacor will have better function in terms of the North Star. I'm sure you're familiar by now with North Star. That is one of the testing we do in clinic. It showed that there were differences in terms of the lung function as well, and there were also significant difference in the height and body weight. Okay, so then this is scoliosis. Again, everybody, I think prednisone and the Flacacor, both of them will prevent scoliosis. This has a difference or some, it can show some difference that maybe patients with the Flacacor will not end up requiring a scoliosis surgery. But I will say my experience with all the patients I have on prednisone, out of 300 patients that we follow in our clinic, we have had 2 or 3 surgeries in 10 years. So really, prednisone and the Flacacors have made a difference. I don't think this is as significant. So when to start them? I think it depends every child. I have little ones that come to clinic at 2, 3 years of age, and I ask them to stand up, and they already have a gower. So you know that there is weakness. You know that there is clear changes, and we all know that patients from the beginning of their life, when they are in the uterus, they're already having changes. I'm pro starting them a little bit earlier, but knowing that obviously we're gonna deal with side effects for so long. So this is kind of like the timeline of discussion. I talked to them about the options. So we have prednisone, we have the Flacacor. Your insurance may not cover the Flacacor. We will do some labs. I always do varicella testing and TB testing. I don't know if it's something that you guys do. We do always that before we start them. And then after that, we have the discussion with the nutritionist to help us creating this plan for the diet that nobody follows, but we still talk about that. And then we start them on the steroids, depending on their response. So if they have behavioral issues, we have to reduce the dose. I personally start patients on less steroids if they do have behavioral issues. So I start with half of the dose, sometimes 2/3 of the dose, depending the case. But there are some other physicians that start with the full dose and then they start coming down as needed. I think, so prednisone the dose, he was talking about just the dosing, we know this part. And then this is one of the studies, a recent study that was the 4DMD. So I don't know if, do you want to help me with this part, or you're not as familiar with this part? Because this study was pro-DMD, so in non-ambulatory patients, their use was associated with delay of decline in pulmonary function, cardiac, and upper extremity. I didn't mention that upper extremity function is also better or more conserved in patients that use steroids. And also in another study in MD-STAR-NET also shows the pulmonary function is better in those patients. And then there is a study from Ann Connolly, and I mean, the point of all of this is to show that yes, the steroids can work and work with loss of ambulation. So I think he just talks about this part. I don't think we have to go through every part. So what can we do about side effects? Changing type of steroids, yes, we can go from prednisone to the Flacacor. We can reduce the dose, or we can have alternate schedule. The problem with the schedule is that the studies that we have now, we know that the use of daily prednisone and the use of daily the Flacacor are comparable, right? That we know. But then the families want to start trying weekend and 10 days on, 10 days off, and it becomes a really confusing thing for everybody. So what I decided is, or you're on the daily dose, or you're on a weekend dose. For the weekend dose, I use Friday, Saturday, Sunday, or Saturday, Sunday, not to have to use such a high dose each day. So the total dose that is needed for weekend is supposed to be 10 milligrams per kilo to start. But if you calculate that by your child's weight, you're gonna end up with a lot of steroids. I usually start with 5 milligrams per kilo, divided in 2 or 3 days, and then I work that up as it goes. It has been helpful, the weekend dose for weight. It has been helpful for behavior, but some people said that it has not, that really doesn't show any difference. And then this is just adrenal insufficiency. Something that I didn't used to do, now I'm very active in doing it, is prescribing the intramuscular injection. Obviously, I cannot give it to everybody because there are some families that do not have the education or the background to be able to have an intramuscular medication to give in case they cannot take the steroids. But this is something important to ask your physician for. The other thing is important if your son is going to have surgery, to make sure that there is a plan to, when the patient is not going to be able to take anything by mouth, then what do we do, how much do we do, how many days do we keep them? And all of this is in the guidelines, and there is this protocol called PJ Nichols that shows everything. It's easy access online, so even if your physician doesn't do it, you can still print it and ask them, say, hey, this is what we have to do before surgery, and be prepared for these situations. I think that's it, that's my part. Again, I just hope that the beginning, what I'm saying is the beginning is hard, the beginning is the most important part, and the beginning is when I think you have to create a very good relationship with your physician and put your foot down a little bit. Put your foot down asking questions, put your foot down requesting information about insurance. Don't just take it, about insurance, not about trials. Don't just take it, just be more active on it. Be active in the process. Thank you.
You know, and if you guys are kind of even more newly diagnosed, I know that all of this seems very overwhelming, and we know too that we've still got a long way to go, but I really appreciate having a neurologist who comes on and also talks about some of the drawbacks of a multidisciplinary team and how overwhelming that is, and also the drawbacks of steroids. And I know as a parent who has seen steroids, they give, but they also take, and I know that that's a lot to take in, but that's why this discussion is so important. And yes, she already stood up because she needs no introduction, but as Dr. Castro talked about just how important diet is, and you mentioned before we started that she kind of wished to see diet talked about for both all the journeys, because she's right, it's important now and it's important always. Right. It's one of the things that we can do as families to really help ensure the health of our kids. So we're gonna turn it over now and really talk about something important, which is diet in the Duchenne journey. Thanks so much.
Thank you. So I am Dr. Kindan Fawcett. I have a PhD and I am a registered dietitian. I work at, excuse me, the University of Arkansas for Medical Sciences, and I'm going to talk about the yen experience. So this is you experiencing nutrition, and later I'm going to talk about the win experience. So why do they let me come and talk at things like this? Like, why do I get to talk? So I have credentials behind my name, all the letters, all the stuff, right? Like, I've done my research, I do my stuff. That's all fine and great. But, I want to go back. This guy, this is Tyler, this is my son. He is 12 years old, and he has been pretty much completely non-ambulatory since he was about 8. So we're talking, had decline, was on his toes early on. He was diagnosed at 5, started steroids, things like that. One day he was still kind of walking and pivoting, and one day he was not. And it was that fast. So I do get it. And I think that this is why I love doing what I do, because I understand. I know the clinical side, I know the research, but I know as a parent, everything that Dr. Castro was talking about is true. We have to ask questions. We have to be ready to say, hold on, wait, no, I'm not okay with that. I want to make a change. What can I do? So this is Tyler, and so the very bottom picture down there in his SWAT vehicle. So my husband is ex-military, and he's actually in full-time in nursing school right now. But Tyler won Halloween. Like, he was so good. Everybody talks about it. He won Halloween. So Tyler, I picked the pictures where he looks super happy and fun, but I tell you, the steroids, it's not always like this, And I do want you to kind of make note, like, there are some significant changes in his facial structure and the moon face, and we've been on different types of steroids. We've done the week dose, we've done the weekend dose, and what has changed, just like they were saying, we changed his diet. And believe me, it's hard. I have 3 kids, and sometimes none of them want to eat. Like, I mean, they want to eat, but they don't want to eat what I want them to eat. So it's kind of one of those things. Am I going to fight with them about eating carrots, or am I going to fight with them about brushing their teeth, or am I going to fight with them about taking their meds? You know, it's always a battle, it seems like, to some extent. And I know as parents, like if there is no battle in your house, please raise your hand, because I want to come talk to you, and I'm sure everybody here does, because I know it. So what I need to succeed, what are my wins? How do I make this work in my family? How do I change the way we eat? And I think Dr. Castro said it perfectly. In different areas of the country and the world, we eat differently. I am in Arkansas. Most of my population is overweight or obese. And I have a lot of kiddos that come in that are 250 pounds, non-ambulatory, in a wheelchair. I cannot keep those things from happening. I cannot keep your kid from becoming non-ambulatory. But I can help you create a time where maybe they stay ambulatory a little bit longer, because guess what? They don't have that excess weight on them. I can keep their heart maybe functioning a little bit better, because we're eating heart-healthy foods, and we're taking, you know, our supplements, and we're eating fiber, and we're drinking our water, and we're doing those things. And I love what you said. We can't control a lot of things, right? Like as parents, you know, we can't. But this is something we can control. And I think that that's why it's so important. So what can we do to help? I kind of have looking at it from two ways, you know, the clinician standpoint and what we can talk to our clinicians about, what we can talk to our providers about, and then also what we can do at home. So number one, knowing how many calories our boys need. It's very simple. We can do indirect calorimetry. That doesn't happen for most people, because usually we attach it to a way to get oxygen and CO2 readings, and then we can tell you exactly how many calories you need. I don't have a lot of those sticking in my back pocket, so what can I do? I have an equation that I can basically tell you how many calories your boys need and then what they're getting. You know, I can give you this equation, and then you can tell me everything they eat, and that's the hard part, being honest about it, because, you know, I don't know why, but there is such shame and guilt associated with food and giving food or taking away food, and nobody ever likes to talk to me because I'm the food police, and I'm like, listen, I'm not the food police. Like, I took 2 cookies last night, and one was for my niece, but I'm pretty sure I ate the other half of it this morning, you know? So we all understand that. So we make small changes. We do our best. So with that, you know, choosing foods with high satiety factor. That's a big word for that keeps you feeling fuller longer. Eat the peel on your apple. Drink water. Take your time eating. Our family, we joke around because my husband was in the military, so he's like, you eat your food and you taste it later. So Tyler is like shoveling it in, and you know, he's done eating, and I'm just like sitting down. I'm like, okay, let's eat. And they're like, we're done. Well, in our house, we have a rule where we eat. It's not that you can't have seconds, but we're gonna sit there for 10 or 15 minutes, and are you really hungry, or did it just taste so good that you just want more? Usually it just tasted really good, and I'm actually full, you know, listening to those hunger cues. In general, we all as a society don't do that. It's like really listening to your body and saying, oh, I am full, I'm content. Maybe I'm not full. You know, nobody wants to be that stuffed on Thanksgiving where, you know, your pants are tight, and, you know, I had maternity pants, which were awesome, and I was like, they should just be maternity pants, but should they, you know? And back to eating correctly, whole grains. Don't, you know, trying to eliminate those white breads, those white sugars, the pasta that's just white. If you do a white pasta, how about you do a protein pasta, so that protein keeps them feeling a little bit more full. Do fruits and vegetables. Like I said, eat the peel. Protein at every meal and snack. So this is a big one, because protein is going to give you that sustained energy. Protein is going to make you have that satiety factor along with fat. So fat has more calories per gram, but, you know, we have to be careful about fats. Like, which fats are we getting? So, you know, some examples I always do is my kiddo likes beef jerky, so we do a low sugar beef jerky. I pretty much keep it in my purse at all times. We do protein bars. I don't want that to be your end-all be-all, but like if you're traveling on a plane and your options are this or a, you know, low sugar protein bar, yeah, do that. But I like to think about whole foods. I like to give my kiddos apples with a nut butter. So they get that fiber, they get that carbohydrate, but they get that protein from the nut butter, and they also get the fat. And then eliminate, it says eliminate, limit, but I say eliminate the sugared beverages. There are so many options that you can do, and we can always get into the debate about sweeteners, artificial sweeteners, things like that, but you know, water is the end all be all. Water is what we should be drinking. Do we always drink it? No. Maybe if your kiddos don't like water, you might suggest sparkling water, soda. We call it fizzy in our house. My 2.5-year-old, he thinks that soda is fizzy. I'm like, let's have some fizzy soda. Yes, we're having soda. So he's gonna go to school and he's like, you're a liar. My mom said this was that. But you know, whatever it takes. But do maybe a Coke Zero. If you guys are a sugared beverage family, maybe try to take one of them out. You know, something that I'm never gonna do in practice is you tell me, you come into my clinic and you say, okay, I drink 12 Mountain Dews a day. And I'm like, okay, well, can you do 11 Mountain Dews this week? Can you just do, you know, today? Can we try it? And I think that that's the biggest thing is people get very concerned that we are going to say, change everything about your life. I'm not gonna do that. I'm gonna talk to you. I'm gonna see what you eat, what you like, what you don't like. I kind of equate it to I don't like to run. I did it in college, you know, I had friends, and I mean, I was considered a runner. I never really liked it. So I'm not going to have myself put on a plan where I'm like, I'm gonna run a marathon. I never wanna do that. So what am I gonna do? I'm gonna fail. I'm never gonna set you up to fail. I want you to succeed. So, okay, let's see, you eat fast food a lot. Okay, well, when you go eat fast food, could we try this maybe? Could we try apples one time? And just go from there. And then water, you know, and this goes into a lot of things we talk about with, you know, hydration and constipation and GI stuff. And, you know, I think it's interesting as we talk about everything should work together. We should all be working together in this multidisciplinary team. Not necessarily clinic, but team. It all works together. We all have a boy, like this one person that has all this stuff that we need. And I loved how you talked about the mental health and the emotional component, because it's huge, and it's something that there are not a lot of out there. You know, we have a hard time finding a psychologist or a psychotherapist that deals with disease populations, specifically this disease. So then looking at it kind of from the physician role, the dietitian role, and the family role. So these are ICD codes. So basically I wanted to show you this to show you that I can find, you could tell me pretty much any one of your boys, and I can find something that I can tell my physician that they can write, then I can bill insurance. So we can get you in, if you have insurance, with your practitioner, your dietitian, nutritionist, whoever you have, and we can help you. So basically, we need a physician to refer you to a dietitian if you don't have clinic. And I think that you made a very good point that let me just ask you a question. When you're in clinic, does anybody feel overwhelmed because there's so much information and you're like, the last thing I want to do, I heard two really good points. I'm hungry, and the last thing I want to do is see another person about talking about food, because a lot of times I'm one of the last to go in, so everyone's like, whatever can Dan, no, not even gonna listen to you. Or, do you have snacks? Do you have snacks? Maybe I'll listen to you. But how do we remedy that? You know, so maybe it is something where I just pop in for 2 minutes and say, hey, we're gonna set up something. We can do telehealth, we can do it from your living room, we can talk at a different time. Maybe that's how it works for you. And then also providing snacks, you know, doing something. Maybe, you know, in our clinic specifically, we have it's the second Wednesday of the month, and we see all our boys just on Wednesdays. So I've proposed, like, maybe we should do something like a lunch and learn, where I can give my information and I feed you something that I want you to try, and everybody kind of has a win. So when to ask for help, seeing a dietitian. You know, a lot of us that are in a certified Duchenne care center we have some guidelines. So it is seeing a dietitian at the onset of steroids. But that's not it. You should regularly be seeing a dietitian, especially if you have some issues with weight gain, with some issues with hydration or constipation or some of the GI things. It is not only, it's not one or the other. It's maybe you see that, maybe you see us at 6 months the first time, then maybe you start seeing me, you know, every 3 months or something, or maybe every month until we get it figured out. And then also, if you have a kiddo that is above or below the growth curve. So if you have a kid that's not gaining weight, a lot of times this happens in the Becker population. What are we going to do? We are going to feed you those milkshakes and things like that. And we had a really great point is, okay, well, these kids, we tell them, don't eat, don't eat, don't eat. And then all of a sudden we're like, oh, you're becoming malnourished. Eat. Here's 7 milkshakes. Drink all these. Drink these, all this food. Like, let's stuff this in you. So the people are like, what? I don't know what to do. So if I could help you start on the beginning to eat healthy and to kind of change your habits, wouldn't that be better than putting you through this yo-yo cycle of do this, do this, do this? And then also looking at if there is overnutrition or undernutrition, looking at glucose metabolism, mobility, respiratory, and cardiac functions. Like I said, if you have a steady, streamlined weight and not those ups and downs, it's going to be healthier for your body in general. And then also, once things progress, we start to have chewing function difficulty, swallowing. And this is where I believe a dietitian should be utilized maybe more so than they are in some clinics, because they don't think about how important it is to incorporate all these different people. So a lot of times, we don't specifically do it at our clinic, but I was talking with other practitioners that every time the dietitian goes in, the speech pathologist goes in. That makes perfect sense, because guess what she does? She looks in the mouth and she holds the tongue and she's seeing if there's swallowing difficulties. And that might be the first time that it's ever diagnosed or ever thought about, because maybe your kiddo isn't struggling or choking yet. So, looking at ways to do that. And then also the big ones are calcium and vitamin D. I'm sure everybody hears about that. I don't know, my son particularly doesn't like milk. He's really just never been a milk drinker. My other ones, they love it. So how do we get that calcium? Because if we don't have that vitamin D, calcium isn't absorbed and utilized, which means our bone health is decreasing. And then also some things that people never talk about are the fact that a lot of our boys do have some iron deficiencies or some anemia. Well, we can't take our iron when we take our calcium and our vitamin D. So it's all of these things that we don't know about that we need that education that you were talking about. And then also, and I think I have run out of time, just the family role. Like, what can we do as a family? And I will go ahead and say the biggest thing is stop the emotional eating. Food does not have a connotation of good or bad. It's food. So we as a parent do have to kind of, she was talking about putting your foot down with the practitioner, but you got to put your foot down with your kid and be like, I love you. Me giving you 7 Oreos does not equate me loving you more. It's me saying, we get 2 Oreos. But everybody in the family gets 2 Oreos. Not you get 2 Oreos and I get 7. And then really just to follow up lastly, nutrition is one of the most important things you and I can do specifically for our boys. We can work together. This is something we can control. I'm a control freak, so I like that. I don't know about you guys, but if you have questions or you need to talk, you can always email me. We can make sure everybody has my email. That's my phone. That's actually my phone number. If you text me, let me know who it is, because I don't want to think that you're like the extended car warranty people. So thank you. I appreciate it.
Oh, you want to? So that was wonderful, and we're going to have some question and answers so we can talk about more of that. And I will say, for us, we have found that having that dietitian, it's not always fun. We dread you too. But I will say we have seen the progression of Grant now starting to take more responsibility for his choices because of that conversation. So we are seeing that becoming easier to deal with. So keep at it, even if it makes us uncomfortable. And our last speaker on this panel today is Dr. Byrne, and he's from the University of Florida. He is a cardiologist that studies these progressive diseases, and so to have someone who's going to talk to us about pediatric cardiology and research is something that we all, I know, are really interested in. So thanks so much.
Thanks so much. So I'm delighted to be here from just up the road in Gainesville, about 2 hours away. We really serve patients from all over the state, and one of my roles as the head of the Multidisciplinary Clinic in Gainesville is to really support both local activities in the state as well as in the region In some cases, we even see patients from as far away as Atlanta. My background, as was said, is in pediatric cardiology, and for the last 25 years, I've really been working as a clinician scientist, principally in the gene therapy area. It's about 30 years ago that gene therapy as a concept was discovered at the University of Florida, and our lab, when I was still in Baltimore, was the first to show that AAV vectors work in muscle in a way that had never been seen before, that they essentially permanently change the gene composition of muscle. And so it's been a long journey to see these therapies now come to the clinic. I'm the investigator of the IGNITE DMD study, which was one of the first to begin gene therapy studies in Duchenne given systemically. And so I just have a few disclosures as a representative of the FDA and the Treat NMD TAC group, as well as the chief medical advisor to the MDA and Pfizer Advisory Board. And I go back a long ways with Cure Duchenne. I've known Deborah and Paul a long time. In 2012, we made it to the top of Mount Kilimanjaro on behalf of Cure Duchenne to bring awareness to Duchenne research. Paul's the tall one there, and right by the sign. And so that was an amazing experience. And my role here today is really just to give you some insight onto how volunteering and participating in research is so important to the future of both all the boys with Duchenne and your son. So obviously the journey begins with the diagnosis. I think you've been through that part. That part is challenging for sure, but also so is the future participation in clinical studies. And one family that we've known here in Orlando is very dear to us in Gainesville said that when she learned her son was ineligible for a study, that was worse than the day he was diagnosed. So we want to try to help you understand that process. And some of what's required in Duchenne is to understand the basis for the disease, understanding how genes become proteins, and how that instruction to make that protein is different in each patient who's affected by Duchenne, and that will influence eligibility for studies. So I'm going to say a little bit about that. And it's a unique problem because with a high proportion of mothers who are carriers, that may mean multiple children, boys in the family are affected. That's one aspect. And then in some cases, we think that the therapies will work independently of the mutation. And in some cases, they're designed specifically for a mutation. And we'll learn about that in the panel on exon skipping, where all those therapies are customized for an individual type of mutation. And there are many combinations of these problems that exist in the Duchenne gene because it is the largest gene in the body. And so the opportunity for errors in the making of the dystrophin protein are significantly more than in other conditions. And so many of the errors are large pieces of DNA are missing. And when that's in the repeated region, the spectrin-like repeats, if the protein is still made but is smaller, this is the cause of Becker muscular dystrophy. So in frame deletions in the region that are not, that have been shown to only cause milder disease, when some regions, particularly at the beginning of the gene, are missing or duplicated, this can cause more severe mutations. And now we're learning that even changes in the very end of the gene actually have an influence on how dystrophin works in the brain. So we know that a portion of children have problems both with cognitive and behavioral issues, and that is related to the type of mutation they have. And so all those ones that really can be replaced by a genetic therapy or an exon skipping therapy are something that's important to understand for your son. So of course, studies in Duchenne require that the diagnosis fits with the study at hand. And so every study really starts with the inclusion criteria that this is in fact DMD, and that is defined by the mutation and the clinical characteristics. In the beginning of this journey, where research was really beginning to accelerate in Duchenne, it really was very difficult to get mutation data, and organizations like Cure Duchenne helped support where providers or payers didn't have access to that information because it was so costly. And so both the Human Genome Project and advances in sequencing technology have now meant that every patient can find out their specific abnormality. And now there's even the possibility of doing additional analysis within muscle tissue to look for unusual changes in the RNA, which can be responsible for the phenotype of a patient. So the cause is defined by the mutation and the clinical features when there's a doubt. And now we also have much better ability to examine the muscle directly through the advent of a type of muscle biopsy that doesn't require surgery. This is something that we started quite a while ago, as well as the group at Nationwide, and we found this is a tremendous tool to avoid having to go to the operating room to further establish the diagnosis or look directly at the muscle tissue. And we've advanced the process of examining those samples in smaller and smaller amounts so that really more really available muscle biopsies can be done without a surgery. The patient must have or participant meet certain functional criteria, and this is also very difficult because there's a lot known now about how to assess the clinical severity in Duchenne, and sponsors have realized that there are floors and ceilings in performance that will influence the findings in a study. So a patient who may not reach a certain level of dysfunction, it's very, very hard to measure a change from that status if they're very young. Or ones who are older may have no ability to reverse that finding. So the functional criteria is important. And then often there are relationships between those functional outcomes and age, and studies are designed to include specific age groups. One thing that we can't change, obviously, in a participant's age, and have to really, we know that often the clock is ticking for everyone to either participate in a certain study or not if their age, inclusion, or exclusion criteria. Of course, there are aspects where outcomes may be related to ambulation, so their walking ability is a key part of being included or excluded. Most studies now require that standard of care therapy is being provided in advance of the therapeutic intervention, so that changes that are seen during the study are not attributed to starting glucocorticoids, for example, in the middle of the study, where they may have be confused for an effect of the drug that's being studied rather than the steroids themselves. And this is a challenging one. The third point here about exclusion is most studies exclude participation in other therapeutic studies at the same time. Usually observational studies are allowed to be done at the same time as an interventional study, but it's an important aspect of gene therapy studies, in fact, is that one unique thing about gene therapy, a lot like in organ transplantation, it's one of the few medical therapies that can't be undone. So participation in a study that involves what is essentially a permanent change in aspects of DNA in the muscle and your functional characteristics of your son after that therapy may influence participation in other therapies. And one aspect of that is we know that there are exclusion criteria related to environmental exposure to parvoviruses in the community, and there are hundreds of types of AAV. They probably all are cross-reactive, and that prior exposure does influence eligibility, and certainly having been treated in a study has a definite impact on the future access to commercial products. That's one of the big focuses of our group, and we're working very hard to try to make sure that there are ways to include all patients, and by addressing the baseline antibody status and ways that's measured, as well as the potential to even reset the exposure given in with one product that would enable access to either incremental dosing or future access to a commercial product. So that's very important about participation in research. And one of the ways that you have access to this research is through the network that was established by the MDA, by PPMD, and by Cure Duchenne to really advance innovations in care. That's the aspect of the MDA that supports the MDA care centers that are around the country. There are 150 care centers around the US, and you can see the number of providers specialized in neuromuscular disease that are participants in the care center network, where it's all multidisciplinary. This is a map of where they are. There's a concentration of them on the East Coast, obviously, because there's a greater population density. But really within your region, and certainly even in your own community, now with the advent of telehealth, we really have much better access to specialists so that they can share the care of your son with your local providers and subspecialists. And just to kind of bring together this all about, you know where to go to learn about the necessary multidisciplinary care as well as access to research. How do you find out where the research studies are? And every sponsor usually has some information about their own study, but they're all aggregated here under the clinicaltrials.gov website. One limitation of this website is that it doesn't provide alerts that may be coming, but you have to go back and revisit it and look for a specific study or condition. So there's a search window, and when you put Duchenne into that window, you can see that there are now 340 studies in Duchenne worldwide, 71 studies in Becker. The distribution across the world is quite striking, and we're really lucky in the US and Europe to have access to these studies. You know, in a perfect world, we would like to be able to provide access to patients from anywhere to studies that are being done at the sites within the US or in Europe. It's very challenging, though, both transportation costs as well as the need for medical insurance when you're out of your home community have made it challenging to provide that care to everyone. But I think that is necessary as we go forward, how the worldwide community of patients have access to the most contemporary care. You can see the northwestern part of the country is not doing so well in terms of participation in research studies, but certainly we have lots of access through other states that are nearby. So it's hard if you live in North Dakota, but for probably a lot of reasons. But there are studies that you can go to, and sponsors support travel. So I just encourage you to not let geography be a limitation to access to a research study. As an example, they range from observational studies, this one being done just at the university on the burden of access to studies and to care in the US. And this is obviously something that we continue to strive to improve. This is what the page looks like to give you additional specifics, the summary of the study, who the patient population is, and how to participate. And there's always a point of contact in these pages. So I'll end there, and I think we can do our Q&A. I always say thanks to certainly our team in Gainesville, and certainly you and your sons and patients around the world in the Duchenne community who are trying to have a better life. So I appreciate the opportunity to talk to you today.
We are going to get to do some questions, and I think there's going to be some mics kind of going around the room. Okay, yeah, Doug right there has one, but I do want to take the opportunity. You know, Cure Duchenne came to Oklahoma, where we live, and had an event, and we invited doctors, and they could not get in our area a single doctor to come and talk to 17 families with Duchenne. And so I know that as a parent, every time that we come to these, it's inspiring to us that we see that you're stressed and we see you're doing so much, and yet you'll come to this and speak to us. And it really is inspiring to us, and we really appreciate it. And so I know that I speak for you guys too. It really does make a difference. And believe me, I've been talking to a lot of the speakers. They got in at like midnight, and yet they're here for us. And so I know that means a lot. So does anybody have one? Anybody want to toss a question? Because if not, I'm going to be asking questions up here. I see one. You guys missed it, but it was actually a tossed microphone just now.
It's like a box.
I thought it was like a cardboard box. I had a question about dietitian.
Yeah.
Our hardest part is getting our parents to understand how important nutrition is. So we try and have great meals for our boy and our daughter. The grandparents do like McDonald's and parties and everything all the time. So or like a pack of muffins on the way home from school with no nutritional value. How do we get kind of them to understand what we're trying to do?
Absolutely, and I think most of us can appreciate this, and that's actually, I was just talking about my nieces here, and I am a little bit more lenient with her than I am with my kids, and my sister's like, stop, but no, so I think a lot of that is something we always do in our family. If we know we're going someplace, I pack snacks, I provide the food I want our family to have. So usually, like if we go to a barbecue or something like that, I take a fruit tray, I take a meat and cheese tray, and I take a veggie tray. So I know that we all have food that we eat. With the grandparents, that can be kind of hard. I mean, there's, the family dynamic, the relational dynamic, but, say, listen, this is not just about comfort and care. This is about health. When you do this to our kiddo and he gets to eat like this, then he comes home and it's a struggle and a stressor for us, so it just sets us back. Grandparents, that's a hard one, but I think one of the key things is just put your foot down and also provide those snacks, like this is what they eat.
I want to make a comment about that because in my culture, food is love, right? And it's a big issue for my Hispanic families. And it's interesting because thinking about grandparents, like my mom, when she came one time and I had my 2 kids already, she thought I was depriving my kids. I was really neglecting my kids because I was giving them a small portion. Because in Colombia, you get like beans and they give you a pool of beans, like you can swim on it, and it's so much food. And now I go back and I try to eat the size she serves, and I'm like, no way, I cannot eat that much anymore. So culturally, it's difficult, and for them, health, for many of our parents, health means you're chubby and you have red cheeks. That's health. So it's trying to help them understand that things have changed and that we have to look, a little bit away from that cultural stigma that they had, and it's just learned a new way. And I think the other thing is thinking families that work so much. I have families that have 2, 3 different jobs, and sometimes going through McDonald's is easier than,
Well, I was going to say, give them a different idea. Bring them, give them ideas, to your kids. You know what? Our kids like those little, blind bags or those little dumb collectibles. But, I mean, maybe, give them a different idea on something they can give to them because they want to give them a treat. They want to spoil them. And we know with our kids with Duchenne, there's not as much they can do. So, I mean, my idea for that, I always try to, look at it, come at it from a different direction. Go to the Dollar Tree and buy them, a bag of all those blind bags so they can spoil them maybe in some other way. Do you guys have more on that?
I was just going to mention, I think that's a great idea. So, we all, it's a possibility we're all still going to go eat fast food. We do. So what are the best choices you have at that place? A lot of places now offer milk and water instead of soda. They offer apple slices instead of French fries, so maybe they still get their chicken nuggets, but maybe we do apple slices with that today. And then maybe tomorrow they do get the fries. But remember, portion size. We all don't need to supersize every time. Small is the regular portion that we should be having.
Anybody else? You got another one? I see one. Mr. Don't hit him. No, that's my husband. I wouldn't. I don't mean it.
Question for Dr. Castro. I know that the issue of the food and the weight with steroids, most families have had to deal with that
Yeah, I'm very close with Brenda Wong, and I have always liked her work. I mean, her dedication for this community is amazing, and I'm following her steps. I've been following her steps for many years, so I have started patients on myself. I don't have a lot of support from the endocrinology department. They don't agree with it. They don't, unless you have an hemoglobin A1C above 6, they don't even think about it. But I personally have done it. I take responsibility. Obviously, I follow up what I have to follow up, and I take care of, but it has been helpful for some of my patients. Yeah.
Anybody else? I see one in the back. Oh, Doug's running.
So maybe I can amplify a little further. Since the effects of gene therapy are expected to be very long lasting, we don't know that that's lifelong, but we do know that if it were even completely successful, they're, at least for the most common approach, to add a smaller version of dystrophin back into many muscle cells, that effectively changes the diagnosis a bit towards Becker muscular dystrophy. So if a study is being done just in Duchenne, not including Becker patients, then by that basis they would not include patients who had had prior gene therapy. The immunological reasons for why gene therapy can't be re-administered under the current regimen that most sponsors are using is being addressed. So I hate to say never regarding that aspect, and I think there are methods where potentially with earlier diagnosis, early treatment will be paired with an approach to make sure that the expression level is sustained over the lifetime. And so the main reason I think that patients are not included in some studies is their interest is understanding in Duchenne itself, not somewhere in between Duchenne and Becker, the effects of a given drug. They're likely to be, though. You heard this morning a presentation by Edgewise where the original intent of the therapy is as an adjunctive therapy. So combination therapies are going to be tested, and some sponsors, like Edgewise, I think, intend from the outset to study their drug initially for safety by itself, but then ultimately it's envisioned that they would be used in combination with other therapies that are very long-lasting, like gene editing or gene therapy.
And I know that just starting out, and just based on your question, I know that there's a lot in that, and I know it's very complicated. And I know that we're going to have breaks and stuff where they're going to be approachable to come and have one-on-one questions with that. My husband is a person who, throughout our process, always reaches out and writes letters to the doctors and scientists, and we always get responses. So I appreciate your question, and you're welcome to see any of us to talk more about this on the break, because we are kind of running low here, but we definitely want to talk to you more about that so you feel like you have an understanding of your choices with that, because I know that's complex. You guys, we are coming to the end to where I don't think we have enough time to do one more question. So I just want to close it here and again thank our speakers, and thank you guys all too for